Good morning, everyone, and welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is it's Q&A Day, trending topics in healthcare regulation. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the questions pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any additional questions. We'll respond to questions posed after the webinar via email. We've posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you'll receive an email later today with a copy of the slides and a recording of this webinar. With that, I'd like to introduce our presenters today, Martie Ross and Kathy Reep.
Thank you, Shannon. Thanks everyone for joining us today. So twice a year or so, Kathy and I get brave and say, let's just answer whatever questions they may have. So at the time you've registered for this webinar, you had the opportunity to submit a question, and thank you to those of you who did so. We compiled those and sort of globbed together a presentation that addresses the topics that were included in those questions. Now, we will probably not score 100 in terms of answering every question that was posed, but Kathy and I will go back through the list tomorrow. Any questions to which we did not address during the webinar, we will be sure to get an email out to you with a specific response. Same for at the end of this webinar, or if during the webinar you want to post a question, please feel free to do so. Most likely we will not get to those during the presentation today, but we will certainly follow up with email, which we hope is always our practice to make sure that we've crossed our T's and dotted our I's with all of you. But so here we sit. Here.
Jump in on that and say that on some of the questions that you submitted already, we might even be reaching out for some clarification from you and then getting you an answer.
Excellent. Well, so here we sit in the middle of September, near the middle of September. Congress is back from its long, lazy Labor Day weekend holiday, and things are starting to gear up. So before we jump into a lot of the substance here, let's talk about where things are in Washington and the potential impact it has on the healthcare industry. So what Congress is expected to do is approve a budget for the upcoming fiscal year by September 30 of each year. Fiscal year starts on October 1. And long ago, the typical process was there were 12 funding bills. They would work their way through committee, they would work their way through the House and the Senate, there'd be a reconciliation, and we'd have a budget through those 12 funding bills together. Somewhere along the way, we lost that process, and we've gone to more of a stopgap measure till the end of the year, and then concluding the end of the calendar year with a large piece of omnibus legislation. For the last 3 years, it's been referred to as the Consolidated Appropriations Act. We've had a 2021, 2022, and 2023 version of the Consolidated Appropriations Act. So where we expect to happen again by September 30 is some sort of short-term spending patch intended to get us through the end of the calendar year. Now, we had thought that some of this back and forth would have been more limited, because if you recall that debt ceiling deal that we had earlier this year, that agreement, that legislation, the Fiscal Responsibility Act, provided some broad guidelines as to what overall federal spending would look like in terms of comparison from prior year. What in fact we're seeing happening in the House right now is Republican leadership is proposing FY23 spending that's about $119 billion below what those targets had been in the Fiscal Responsibility Act. So you can expect that we're already going to have some political meanderings back and forth as we get to appropriate spending levels. On the other side of Congress and the Senate Appropriations Committee has actually approved their spending bills, and they are consistent with the targets that were in the FRA. So we will have to see how this is all going to end up going back and forth during this month and see what, if any, short-term stopgap measure we end up with. However, just to make things more interesting, as part of the debt deal, Congress agreed that if they were under a continuing resolution, i.e. a stopgap spending measure, as of December 31st of this year, an automatic 1% across the board sequestration would kick in. That was intended to be the disincentive to this pattern that we had developed over the last several years, and instead do the more methodical, approve each spending bill for the entirety of the fiscal year. So that's the extra intrigue that we'll be dealing with as we go through the fall, nearing the end of the year. Because if we do, again, what happened in 2022, which the final spending bill for FY22 wasn't approved until March of 2022, so almost nearly halfway through the fiscal year. But if that happens this time, then we're going to see, again, another across the board 1% cut on all federal spending.
Providers and others receiving federal funding will receive a cut because they didn't do what they were supposed to do. Is that what you're kind of hinting at?
I hope it's not even hinting. I'm intending to say it pretty dang straightforward, Kathy, but that is, in fact, what's at the table. So the stakes are higher for us than usual. And so we don't want, we can keep the bubble gum and duct tape in place until December 31st, but at that point, we need true actual spending bills across all of the 12 agency line items, or we face that 1% cut across the board. So just to start on a positive note, as we deal with some other
topics. How many days are left in September, and let's take out weekends? Because those are not normal work days in Congress?
Exactly. About 8 or so. Again, I mean, but we have to have, there'll be a stopgap. I mean, the alternative to the stopgap measure is everyone's favorite thing, the government shutdown. And I think that's highly unlikely, given prior public reaction to the shutdown, is we'll end up with some sort of continue at current levels or continue at current levels. With some multiplier effect. Yeah, exactly. So, not surprisingly, the most common topic on which your questions dwelled was the No Surprises Act, which is certainly an interesting topic at this point. So, Kathy, I will turn it over to you to give us a current status update.
Okay, and you are in charge of the slides because I'm afraid to touch anything here. Marty and I are both working outside of our offices today, and therefore it's a little awkward, I think. We apologize for any background noises that could come from spouses or dogs. Just warning you now. But I think everyone is aware that under the No Surprises Act, the Texas Medical Association continues to be successful on all of their challenges to the various interim rules and guidance that came out from CMS related to the NSA, the Independent Dispute Resolution Process, and it's the way it was, the IDR entities were being instructed to do their job. So the last victory that came out from for the Texas Medical Association was really looking at the qualifying payment amount, the QPA, and how that was calculated or was suggested to be calculated by CMS actually the various agencies. The rulings that were included in the final decision and this victory was, first of all, the use of ghost rates, where you actually have a payer in establishing their qualifying payment amount would use a rate that is never going to be paid. It is not one that has been calculated. That, I mean, it's out there. They were instructed that they could not use $0 amounts, but they could use anything else. So if I had a contract that said that I was going to get paid for hip replacement surgery at $1, then that could be counted in calculating the QPA, even though I don't do hip replacement surgeries. So that was a success in terms of actually using rates that are payable or would be payable. The issue of specialty rates was also addressed. This was going to be the additional payments for bonuses and things like this. That was also addressed. And ERISA plan administrator rates, those were addressed in this rule as well, because this was whether or not, if you were paying someone from a plan administration perspective, Those are included in the QPA. So everything was, there were a couple provisions on which the providers were not successful, but I don't think TMA is going to appeal these. At least I haven't seen that they are. So where are we right now? What we have is, first of all, if you had submitted an IDR request prior to August 3rd, it is going to continue to be processed and it would be moving forward. They are not accepting any new IDRs through the portal. And there is concern in terms of the impact on patient cost sharing, because if there is not an IDR being processed, it is this question of what does the patient owe? Will the patient responsibility be going up? Will they be asked to pay more, at least during an interim period, until we can we can actually get a final payment amount? And then we were told from CMS that they would be publishing regulations later this fall. So on the next slide, we can see that we actually do have two pieces of proposed rule. We'll go back one more, sitting at the Office of Management and Budget. The first rule is an independent dispute resolution operations proposed rule, and the second is an independent resolution process fees proposed rule. This is different than what they've done in the past, because in the past they have published interim final rules and have never gotten around to finalizing or responding to comments or anything else on those interim final rules. What we have sitting at OMB now is proposed rules for which they would have to accept comments. Now, I have seen some rules in the past that, because of pressing issues, they have only given a 30-day comment period on, but usually you have a 60-day comment period and then review of those comments and publication. These are sitting at OMB. If they came out tomorrow, we are still looking probably at end of the year before we're going to have a final rule, and that would be if they push it. So it's my feeling, Marty, I will ask you for yours, but we aren't going to see the IDR portal open before the end of the year.
I'm not going to bet on this one, because in one of the prior TMA litigation, they closed the portal for a couple of weeks. Then they published interim guidance that was applicable to IDR initiated after a certain date. So we may see that just to keep things moving forward. But it's certainly, you kind of want to, at some point you'd say, do you just start over, because this has become so complicated in terms of the layers of regulatory language and guidance and sub-guidance on it. It's becoming very, very confused on how these rates will be determined.
Their guidance has gotten them into a situation where we have more and more court cases as a result of it. The one thing, if on the operations rule in particular, as you see a proposed rule on that, one thing that I think it's very important that you address is the period where you have not been able to do a dispute resolution, and clarifying that the clock has stopped and it will pick up again. It is not counting at this point, and make that very clear that they address that in regulation.
So we had a couple of questions around the issue of how the federal and state processes work together, because it's very confusing that we had a number of states, more than half the states had some process in place for resolution of out-of-network charges, and then we dropped the federal system on top of that. And so it's difficult to reconcile which system goes where. The important point to remember is the federal rules apply up until the end of the open negotiation period. So the period where you have a claim, you as a provider have a claim that's subject to the No Surprises Act. You submit that claim to the payer. The payer is required to provide you the QPA. You then use the QPA to calculate the patient's responsibility. You then, when you've received payment for the claim, if you're dissatisfied with that payment from the payer, your next step is to initiate this open negotiation period with the payer. That still remains, even though we've had the shutting down the IDR process, that 30-day negotiation period still remains. That's still your remedy, regardless of whether you're going to follow the state or federal IDR process. Your remedy at that point is to go through the open negotiation period. Now, you see here on the slide, whether you are going to go to a federal IDR system or a state IDR system depends on the state in which you're located. There are states with self-funded plans. Self-funded plans are always going to be under the federal rules, except in those states that provide the option that a self-funded plan can utilize the state system if it wishes to do so. Otherwise, you have state law that is determining out-of-network rates for fully insured plans in about 20 of the states. So be aware of which system you have to go to appropriately. In fact, that is the most common reason for a claim to get kicked out of the IDR process, is that the IDR determines that, in fact, there's a state process that's applicable to the specific claim. We had some questions regarding, well, does a payer have the ability to create its own system for the resolution of these claims? And they do, and they can ask you to follow that system, but you have the right to either use the state system or the federal system. So you can effectively waive your right and say, okay, well, we'll not go through the federal IDR process. We'll instead use the payer's system that they've created for the resolution of these disputes. But they cannot force you into that system. That is a voluntary decision on your part to cede what rights you have under either the applicable state or federal IDR process. And even in this period of time where the federal system is frozen, again, they can say, well, instead of using, because the federal process isn't available, let's use our system. You, of course, as the provider, can still say, no, we'll wait for this matter to be resolved through the federal IDR process, or again, if the state process is applicable, to use that process.
Thanks, Marty. Got a lot of questions related to price transparency, and some of the questions actually made me very happy because it indicated that you listened to a previous webinar that we did related to some of the proposed legislation pertaining to price transparency. So we'll talk about that legislation, but let's talk about regulation first. So from a regulatory perspective, in the outpatient proposed rule, comments were due on Monday, September 11th. But included in that proposed rule was revisions to the current requirements for posting your machine readable file in particular. And CMS was very focused on the format of the file, essentially giving two different formats that can be used. One of those formats having two versions, either wide or long. And requiring, I think this is very important, requiring that all of the fields, the required fields like your license number, your date of update, etc., those all be encoded. In other words, they go into a particular box. And the proposed rule also indicated with the changes to the format that the requirement would be effective as of January 1, but enforced as of March 1, 2024. The concern with that is that we aren't going to get a final outpatient rule until probably at the earliest the 1st of November. Then you've got that rule, and you've got very little time to modify your formats. Now, if you posted originally in something that is similar to what CMS is proposing to use, then you've got a part of it done. But I am concerned, having looked at a lot of different files out there and the formats, that they're kind of across the board, and a lot of providers are going to have a lot of work to do at the same time that you're going into perhaps the beginning of your fiscal year, you're going through holidays, things like that. Take a look. We've given you the link in the slides for the sample formats that CMS is working with. Hopefully you did comment on that proposed rule. I know the American Hospital Association and others had very extensive comments in terms of moving forward with changes to these files. Others merely said, from what I've been able to see on the comments that were submitted, issues related to multiple locations and issues related to the March 1 compliance date. So you might even go into the Federal Register website, put it in your questions if you would like a link to that. You can actually read the comments that others have submitted. We are continuing to see providers
Kathy, hold on just a second. I know there were some questions on the price estimator, the provision in the ops rule about price estimator. Would that also go into effect in March? Is that their intention?
No. That was in legislation, not regulation. That comes on the next slide, Marty.
So easily confused. Apologize.
No problem. Okay. Thank you.
Okay, so price estimator still same as it was under these regulations,
yeah,
right?
And we'll talk about legislation related to that. So we do have additional providers that have been fined this summer. We're up to 14. Just, I would say last week, we had an additional 4 that were added, or 3 that were added. I've given you a link, the enforcement actions link. And I urge you to take a look at it. What they've posted here is the communications that they have sent to providers with their request for to pay via federal ACH wire transfer. Okay, and it just gives you the format, the information, the codes you're supposed to use on the wire transfer. But the one that I happen to have in front of me right now, the request was for a wire transfer for $847,740. And it says we may impose additional civil monetary penalties until we determine that you are in compliance. So this is what you owe us right now. But we have the right to continue to assess penalties until you get your data up. Other thing is these letters that are being sent are open and available for everyone to look at. And some of them kind of remind you that when things change within your organization, you have certain steps that you need to follow. I'm just not going to give the name of the hospital, but this is public information. A warning notice went to this particular hospital. CMS is no longer sending warning notices. Okay, but in response to the warning notice, CMS was informed that the interim CEO to whom the notice was addressed is no longer affiliated with the hospital, and that all further communication should be communicated to you. This is the person who received the letter, the hospital COO. Folks, if you have an interim CEO or an interim anyone who is listed with CMS to receive correspondence and they aren't there anymore, 2 things. Number 1, update that file the minute they leave. And secondly, make sure somebody else is opening the mail. I think to me, it really scares me for them to say the interim CEO to whom the notice was addressed is no longer affiliated with the hospital. And so start forwarding the information elsewhere. That's concerning. To me, the other thing that was concerning is the fact that you get this letter saying, please send us $847,000 by wire transfer.
So earlier this summer, we walked our way through several pieces of pending legislation in Congress that addressed price transparency as well as other issues. And they were coming out of the House. These bills were coming out of the House relatively fast and furious. And they were holding very long and detailed committee hearings. The votes on a lot of these bills were bipartisan, unanimously advancing the bills forward. What happened last week is the leadership of the 3 primary committees that were addressing these issues got together, swept everything into HR 5378. So the Lower Cost, More Transparency Act is the bill. This is now the vehicle that will go forward this fall. to work on an assortment of healthcare related issues. And as we go through these provisions, you'll see it has a bit of a kitchen sink appeal to it. And most likely we'll see more provisions added to it through the debate and the voting process. I've read reports that we could see a vote out of the House as early as next week on this particular legislation. There's nothing really comparable going on in the Senate, so we'll see what happens when it crosses chambers. But Kathy, let's drill down on just the transparency provisions in this legislation.
Sure. Let's from a transparency perspective, and this kind of relates to one of the questions we got, and Marty did the lead-in for this on the previous slide. But we talked previously about some of the bills that had been introduced in Ways and Means and Energy and Commerce, essentially addressing the fact that you were going to be required to have a shoppable services file, and you could not rely on a price estimator as an alternative. You could have a price estimator, but you couldn't rely on that as an alternative. Well, what we see in HR 5378 is a requirement for all providers. We'll talk about providers in a minute. For all providers to have that shoppable services file. It also even got to the point to say, when you're outlining the shoppable services file, to say you would be listing 300 shoppable services. If any of the 70 that CMS described you don't furnish, then you need to say, I don't do this, not just ignore it. But the 300 shoppable services, nowhere in 5378 does it address the machine readable file. This is all very focused, I mean, in terms of format. This is all very focused on the shoppable services. It addresses the fact that you are going to be required to have this, at least 300 items. It defines shoppable really as those items that individuals are looking for. It also expands this requirement to diagnostic labs, to providers and suppliers furnishing imaging services, and to ambulatory surgical centers. Now, when it addresses the ambulatory surgical centers, it is those ASCs that are associated with, they defined a specified ambulatory surgical center as an ASC with respect to which a hospital or any person with an ownership or control interest in a hospital has an ownership or control interest in the ASC. So it's not going to be all ASCs that are going to be out there, but take a look at those provisions. Marty, you had a comment when we start talking about providers and suppliers of imaging.
Those are physician practices that have, x-rays and CT scanners and all of that. Those imaging services, now you're potentially, at least as the legislation reads, you're going to be subject to transparency requirements in posting the prices for those services. But again, the devil's in the detail, or as we call it, the regulations that CMS publishes to implement that requirement.
One of the questions that we got, I thought it was a great question. Do you recommend that health systems have a strategy for how best to comply with price transparency and remain competitive? Well, based upon 5378, you better be compliant, because you're not going to be financially competitive based upon the new penalties that are associated with 5378. I'll give you an example. If you are a hospital with 30 or more beds, this goes through this very specific, what would the penalties be? Penalties are going to be higher for non-compliance. You are, if you have 500 beds, more than 500 beds, your penalty for non-compliance will be no less than $5 million and no more than $10 million. I mean, we've been shocked when we see a $900,000 penalty on a hospital. Now we're looking at a minimum of $5 million on a hospital with 500 beds. hospital with between 300 and 500, between 2 million and 4 million. If you are 30 beds or between 30 and 100 beds, it's between $500,000 and $1 million. The dollar penalties associated with this are huge, and therefore, if the issue is being competitive with the guy down the street and how much they've contracted with the same payer for, remember, they've probably posted the information. The payer has posted the information. It's out there as well under the requirements for transparency and coverage. It's just hard to find. But I think I think the penalties that are included in this particular provision are huge. I think there is also a provision in this legislation that would require a review of each hospital's or each entity's posted information at least every 3 years.
Yeah, a regulatory review by a third party. Yeah,
like not
survey, right.
Look at it, but that someone else is coming in and looking at this information. There is also information included in this. I thought this was interesting because if you go back to the CMS draft formats for the compliance for the machine readable files, one of the things that they included in there, and a lot of people asked questions about, was financial assistance policy. Well, what we wind up with in this legislation is actually a requirement that your shoppable services file include information related to financial assistance, and that you actually be able to link the patient to it and show a sliding scale based upon income as to what an individual would owe for a particular service. Looking for that real quick. But it is in there, but it is a requirement that you actually post the information for the beneficiary's perspective. The information related to transparency and coverage, remember that is for the plans. They are requiring compliance by 2026, I believe. And then from a pharmacy benefit manager perspective, they are also going to be required to provide employers with information on drug acquisition costs, out-of-pocket spending, and formulary placement rationales. Martie, do you want to touch on the HOPD while I find the financial assistance?
Sure. Just on TIC real quickly, transparency and coverage. If you recall, these provisions were in the Consolidated Appropriations Act of 2021, and they had a compliance date of 2022. And what we saw happen was that the payers producing enormous files that really were not usable even at a research level because of just the sheer bulk of the data produced. What's intended here in these provisions within 5378 is to make the requirements more bite-sized and more usable information. So that's the longer compliance date, that 2 to 3 year compliance date is intended to be able to build the files so that in fact all of that plan data becomes available in a comparable manner to how hospitals are posting their price transparency data today. Again, on the kitchen sink side of 5378, we have the payment parity provision that's limited to off-campus HOPDs for drug administration services. So those would be paid not at an ops rate, but instead at the lower estimated physician fee schedule rate. Alongside that is the requirement we had heard previously floated, but creating a separate provider ID for each off-campus outpatient department of the hospital with an effective date a couple years down the road. This legislation also includes extended funding for the community health centers, the National Services Corps, the Teaching Health Centers Graduate Education Program. There's also funding in there to continue a special diabetes program that was set also to lose its funding at the end of the year. And probably the good news within this legislation is Congress proposing to delay the start of the Medicaid DSH payments for another 2 years. So those would not begin until FY26. As you recall, this is about the $8 billion cuts that are on the horizon related to Medicaid DSH. What's not here? Importantly, on this, what else needs to be thrown into this bill? It's the physician fee schedule fix. Because as you recall, under the proposed physician fee schedule, we're looking at a pretty significant cut in the conversion factor. And that is a result of adjustments that CMS made to relative value weights, as well as the legislation mandating a cut of a certain degree as well. Now, CMS's answer is going to be, this is Congress's issue. We can't create a higher conversion factor unless we reverse all of our adjustments to relative value. So if there's a doc fix to be had, and additional funding for physician fee schedule reimbursement, it's going to be a bill like this, for this omnibus healthcare legislation, that we'd like to see that included, and it's not here yet.
One thing that is included, going back up to the transparency provisions, is that the Secretary is required to take reasonable steps to ensure the accessibility of the charge information to individuals with limited English proficiency. Such steps may include the hospital's provision of interpretation services or the hospital's provision of translations of charges and information. So think about taking what you have posted in your shoppable services file and making that available in to those who have limited English proficiency. And then it also does address when it's in its definition of shoppable services, it's what we have seen in the past related to something that can be scheduled in advance. And it requires a separate identification of, well, no, that one Marty did. So that was it for me on that one.
Yeah. Stay tuned on this. I mean, the legislative text was not released until Friday. There isn't even an official CBO summary on this legislation yet, but certainly it has the potential to move very, very fast. And it's a trade-off bill. I mean, a lot of these transparency bills were passing this summer, again, unanimously. Other provisions were not. There were more party line votes on these. But it'll be interesting to see, how this plays out politically and what's in the bill that the Democrats will hold their nose and vote for on the Republicans' priorities for some of these more stringent regulations around hospitals and healthcare providers.
Just a couple of billing updates from CMS that we wanted to touch base on. The first one that we wanted to do, relates the validation edits for providers with multiple service locations. Beginning August 1st, we found that hospitals were having issues when they submitted claims that they were not getting through the system. CMS did publish communications in terms of what was the problem. If you have a multiple off-campus outpatient provider-based departments, you need to make sure that the information from an address perspective that is on your claim matches the information that is in PACOS. Don't put ROAD on your claim and RD in PACOS. You need to be very clear that both are matching, because the claims are being not processed, they're being kicked out of the system. And so this is an area that just making sure that you are aware requires your verification of your system. The next one is the JW and the JZ modifier. This is an issue that providers have raised in the past, we wanted to make sure that you were aware that CMS had released a number of FAQs related to the use of JW and JZ. This was, as of July, the requirement for compliance with this, and it does apply to not only hospitals and ambulatory surgical centers, but also physicians and anyone else who is billing for Medicare drugs and biologicals that are from a single dose container or single use package. The requirement is, first of all, JW, is where, and we've used JW for a long time, reflects the discarded amount of drugs. So if you had a single dose container and you didn't use it all, how much did you discard? And you had to reflect, using a modifier, the amount that was discarded. CMS has now put in place the use of the JZ modifier, which says that out of this single dose container, I didn't discard anything, I used it all. Now, gut feel, if you didn't use JW, then it should mean that you used it all. But no, we have to have two modifiers, JW and JZ. One is when you didn't use it all and you reflect the amount that you did not use, and the JZ, which is when you did use the entire packet. And Marty, home address?
Okay. This is sort of a leftover from the end of the public health emergency. You recall during the PHE, a physician, a practitioner could furnish telehealth services from their home, much like Kathy and I are doing webinars from our home. And you were not required to update PACOS enrollment information with the practitioner's home address. They could continue to list on the claim the address where they normally practiced and saw patients face-to-face. CMS, at the end of the PHE, announced that it would continue to permit that practice through the end of this year. So no need to update PACOS until the end of the year. But now the directive is by January 1st of 2024, if the practitioner is still furnishing services via telehealth from their home, their PACOS information needs to be updated appropriately to include the home address. The question we can't answer, because we are still waiting for CMS guidance on this point, is this required even if it only happens once? Or is there some threshold of frequency? So if it's, twice a week, do we not need to worry about it? But if it's 10 times a week, we do need to change the PACOS enrollment information. CMS has not addressed that issue directly, at least in any published guidance. The other issue with regard to posting of personal home addresses is a concern because PACOS information directly links to the Care Compare website, meaning that if you updated PACOS with a home address, then when someone pulls up Care Compare for that physician, there's the physician's home address. So obviously that has its own set of concern. From the Care Compare website, you have there the quote, the directions on what a provider should do if they do not want their personal information to be displaying on their Care Compare page. And the directive is send an email, and that's a hyperlink, with the correct contact information so that we'll suppress the home address. But when you keep reading, you'll see, but this is only an every 6-month fix because we update to PACOS every 6 months. And so if, at least as it stands today, until we get further guidance from CMS on this particular enrollment issue, you do need to add the physician's home address. And if they don't want that to appear on Care Compare, every 6 months, you're going to be needing to send an email to ensure that that information is not publicly posted then on Care Compare. I suspect we'll get something more from CMS. I was surprised this wasn't addressed in the proposed Medicare physician fee schedule rule, but enrollment guidance tends to come out as sub-regulatory guidance anyway. We'll keep our eye out on this particular issue.
We did have one person who commented when we asked for questions that they were very interested in anything that related to post-acute care, skilled nursing, etc.
Well, what you asked for.
What you asked for, all right? Because we did get a proposed rule September 1st with comments due in November 6th, relating to nursing home staffing mandate. The administration had indicated that they were working on something, that they were concerned about the staffing in these post-acute care facilities. And so now they have actually proposed some changes. And getting some definite, go back again, Marty, went too fast. First, they are, from a minimum nurse staffing perspective, they are requiring 0.55 hours per resident's day for an RN, and nurses aides a minimum of 2.45 hours per resident day. Well, what's missing in that picture and who provides a large part of the care that is given in many nursing facilities, and that is LPNs, licensed practical nurses. And there's a lot of media attention right now on the fact that this rule did not even address them. And what does that mean? Are they considered in this a nurse's aide? They aren't an RN, but for a large number of providers, the LPNs are doing the majority of the patient care. The RNs are doing the supervision, but again, LPNs aren't addressed. According to press releases on the rule, this would result in need for increased staffing at 75% of the nursing facilities across the country. And this standard is higher than any of the state requirements that are currently in existence. Concern here is we already have within our hospitals concerns about nurse staffing. And now we're suddenly going to be definitely competing on RNs and others with the nursing homes as well because of their requirements for minimum number of hours per day. This requires an RN on site 24/7, 365. So that's at least 3 RNs for every nursing facility. And you would think then you're going to start doing your math based upon how many residents you actually have. So very concerning in terms of where this rule will go and where the comments are needed. They are also looking at some enhanced facility requirements. They want you to be able to reflect that you used evidence-based methods in care planning, and that includes those residents with behavioral health needs, not just your medical patients. That you would need to use your facility assessment to gauge the needs of each resident and adjust that assessment as needed. You've got to have the staff input into this, and you also have to develop a staffing plan to maximize recruitment and retention. Not sure how you do that when there is a demand from the competition for staffing. In terms of compliance, they split compliance and implementation based on urban versus rural facilities. For urban facilities, you would have to comply with the assessment requirements for patients within 60 days of the final publication, of the final rule. You would have to comply with the RN 24/7 requirement within 2 years, and the minimum hours per patient day staffing requirements, that would be within 3 years. So, time would definitely be, you'd have 3 years to become compliant with all of the requirements. For rural facilities, again, the assessment requirement, 60 days, RN 3 years rather than 2, and the minimum staffing requirements, hours per patient day, you would have 5 years as opposed to the 3 years that is on the urban facility perspective. I think it's going to be an issue of, can we do this? Or will we see nursing facilities close and it becomes an issue on hospitals with not having a place to discharge patients? Marty?
Stay tuned. Well, so let's get a lot of questions around proposed regulations and regarding the status of those proposed regulations and what, if anything, providers should be doing in anticipation of those proposed rules. So these are, the beauty of like OPS and IPS and fee schedule is they're on a schedule. We know that rules are going to be published in the spring. In the spring, the final rules will be published later in the year. We know when to anticipate them. Otherwise, when CMS is in a regulatory mood and publishes a proposed rule, we don't get a timeline on when to expect the final rule. And here are just, these are the primary rules we're watching. Kathy and I are the obsessive compulsive care that check the OMB dashboard on a regular basis to see if any of these are in the mix. Because once the agency drafts the final rule, it has to send it to OMB to be scored. and then it's released from OMB for publication. The one that we're really nervous about is the standard for identification under the 60-day overpayment rule. If you recall, this had actually been tucked into a rule published at the end of last year, which was the Medicare Advantage policy and technical changes for CY 2024. When CMS published that final rule in April, they said that it would delay the publication of the overpayment rule because it decided that it needed to be addressed or in a more single fashion than including within the MA rule. This is a scary provision because this would change the standard for knowing when you have an overpayment. It now becomes the standard of knowingly receives or retains an overpayment, which kicks in the obligation to refund within 60 days. And in failure to do so creates that potential liability of the False Claims Act. So we are watching this very carefully to see when and maybe if CMS does come out with the final rule on this particular issue.
Or what they sneak it into.
I'm sorry?
And yeah, what they sneak this into, because I am not expecting that there will be a rule that says overpayment rule. It will be something that is merged into another document like the 2025 MA policy and technical changes rule.
Well, they did say that they didn't think it was appropriate to address it in the MA space because it had much broader application than MA. It was any overpayment from any federal healthcare program is the application for it. So
okay.
We'll see what goes up. The advancing interoperability and improving prior authorization process, again, another one of those rules that got dumped at the end of last year, beginning of this year. These were the procedural requirements around prior authorization processes. So the manner in which PA requests are submitted, the time period for processing those, all of that. So the procedural aspects of how prior authorization requirements should work. Those are still pending, and we don't have a final rule there. Now, in the MA final plan, in the MA final rule that published in April, CMS did provide us with guidelines on the substance of how those PA requests are to be processed by MA plans, but they didn't address these procedural issues. And again, these are broader than just MA plans. These are broadly applicable effectively to all payers and how PAs will be handled going forward. 1557, which is the section 1557 of the Affordable Care Act, but it's referred to just now as 1557. This is the provision that prohibits discrimination of any kind in federal health care programs. Proposed regulations published in July of last year still have not gone final. Those proposed regulations particularly address the scope of 1557 and to what plans it applies to. There have been regulations published in 2020 that really narrowed it in to certain types of programs, and this proposed rule, if finalized, would again expand the application more broadly. This particular issue, 1557, is limited English proficiency and the obligations to provide translation across all federal programs. So we're waiting on that. There's a whole set of HIPAA rules that are out there dating back to 2020, where we had the proposed rule that broadened individual rights protections and attempted to reduce administrative burden on providers. Still waiting there, as well as the two 2023 rules, which would update the information blocking requirements, as well as the HIPAA provisions regarding reproductive health care. All of that still pending, and we'll wait to see when CMS may finalize those. The one rule we do know that's coming, and we expect it to be published before November 11th, is the Drug Enforcement Administration's rule on teleprescribing for controlled substances. Again, harken back to the PHE. Under the Controlled Substances Act, DEA waived the requirement that there has to be a face-to-face encounter between a prescriber and a patient prior to prescribing any controlled substance. That ended with the end of the PHE. DEA stepped in, had published a proposed rule that literally everyone hated. It is probably the most highest comments. I was saying, like, what, 36,000 comments on it, Kathy?
Right.
So DEA, said, "Uncle, we'll just keep the current rule in effect until November, but we'll be publishing a final rule that will address teleprescribing of controlled substances. So keep your eye out. We'll be seeing something this fall on that particular issue. But otherwise,
on that as well.
Exactly. So stay tuned on these. Another question we had is, what do you anticipate happening following the OIG's announcement that it was going to modernize its compliance program guidance? This was a Federal Register notice that came out in April of this year, and OIG promised that it had plans to improve and update its existing compliance program guidance, and even to deliver new industry-specific compliance program guidance. So between 1998 and 2008, over a 20-year period, CMS published 11 of these industry-specific compliance program guidance. It updated several of them on several occasions, but it really has been radio silent since then. And it has been radio silent since April, promising modernization. The only thing that we know at this point is that these are now all on the OIG website. No longer will be published in Federal Register, instead just posted to the website. So again, we're keeping an eye out on this to see if their expectations are changing, or if we get more specific guidance directed to a specific industry. Questions on CMMI models and what CMMI is proposing in terms of new alternative payment model. They've been busy this summer. They proposed 3 new models: Making Care Primary, Guiding and Improved Dementia Experience, the GUIDE model, and the State AHEAD model, which is a multi-payer total cost of care model. So you can read briefly about what's going on here. The only one of these that has a current application period is the Making Care Primary model, limited to 8 states. It is sort of the next generation of the primary care models that CMS has been announcing. And we're going to close out here on, I think, one of my favorite questions we got, which was, what should we be talking to our compliance and audit committees as risk areas for 2024? So Kathy and I kind of put our heads together and came up with our list of favorites. No surprise here is we thought price transparency, because of anticipating increased enforcement, new regulations, new legislation is something we definitely need to keep our eye on the ball. And apparently it's going to go beyond just the hospitals, that we're potentially in this pending legislation have other providers included. With regard to the No Surprises Act, good faith estimates are still out there. It's been quiet. We will continue only to have to provide a good faith estimate of our own charges and not other providers' charges. But we have seen enforcement activity in this particular area of providers failing to give estimates or providing incomplete information in their estimates.
And we still have that, the advanced explanation of benefits that comes with that as well.
Right. Diagnosis coding accuracy, a lot of OIG activity here, primarily geared towards the Medicare Advantage plans, and submission of diagnosis coding that is not accurate, that thus drives up the HCC and then drives up the MA plan payment. I think there's going to be a lot around this, in part because this is becoming a much more automated process. There are solutions out there that are identifying missing diagnoses from patients based either on prior claims information or a data that's in the EHR. There's artificial intelligence that's now being developed around coding and diagnosis accuracy. So I think there's going to be some space, some activity here. Not exactly sure what it's going to look like, but certainly an area on which to focus. Provider relief fund audits. I think HRSA's through the easy stuff, right? It's gone through the reporting, failures to report, the obvious fraud, but I think we're going to start seeing some deeper dive audits into how you spent your PRF funds. Again, just a reminder to have the documentation in order in the event that those audits start. And as Kathy noted earlier, make sure you have up-to-date contact information, because the last thing you want is a PRF audit where no one finds out you were doing it.
And if the previous CEO has left, please still open the mail.
Exactly. Documentation to support virtual direct supervision. Now, we've started hearing noise around this. Some audits that have been occurring for services that require direct supervision during the PHE and now continuing through the end of next year. We are allowed to provide direct supervision virtually, using the good old iPhone to provide that service. But we're hearing some grumblings around how are you documenting that, in fact, there was a provider identified who was available to provide assistance in a virtual means. And so maybe worth going back and looking at what your practices were to ensure that you've got the documentation to support and to be able to defend that, in fact, direct supervision was being provided. We'd be fools not to include cybersecurity on a list like this. That is always a hot topic. I think I'm really going to be interested to see what happens with this complexity add-on code. So this is the provision in the Medicare physician fee schedule that allows providers to add on a code to increase the reimbursement for E&M services provided on an ongoing basis for a beneficiary. The documentation guidance is really thin that we've seen from CMS. So where will providers go in terms of adding this code on? And then it creates all sorts of issues with regard to WRVU-driven physician compensation models, because you're going to see RVUs go up for physicians that include this add-on code, and how are you going to manage that within your own compensation plan?
And you're going to add on audits.
Yes, exactly. Kathy, I'll let you talk about site neutrality then.
Okay, and just on the site neutrality, we talked a little bit about the issue of drug administration being included in the legislation pending in Congress, but this is a big issue. The Medicare Payment Advisory Commission talks about site neutrality and the issue of services that are provided in a hospital setting, whether it's on campus or off campus, being paid the same as that service provided in a physician's office or in a non-hospital affiliated setting. The issue here is, like even with MedPAC, they have addressed the fact that if it's an emergency type service or certain services that could only be provided in a hospital setting, we aren't concerned about those from a site neutrality. But when we're getting into clinic visits, when we're getting into, as we're seeing in the legislation, drug administration, things like that, the question of should those continue to be paid at the same rate? We do have the issue with off-campus provider-based departments and those that were grandfathered prior to November 2nd, 2015. Recognize that most of the legislation that is addressing site neutrality does not consider grandfathering. If you are off campus and you are more than the 250 yards, you are paid, you would not be paid from a hospital perspective, whether you existed in 2015 or not. So very concerning in terms of taking a look at what you provide, take a look at reimbursement for off-campus areas under the physician fee schedule versus under the hospital outpatient prospective payment system, and start looking at, should I move things? Am I okay leaving this here? You know, when labs are paid under the lab fee schedule, it's paid the same thing, either location. Cardiac rehab is now being paid the same thing, or based upon the outpatient proposed rule, would be paid the same thing. Take a look at what, I mean, do we need to start looking at moving drug administration as an example? And unfortunately, for the patient, do we need to move drug administration back into the four walls of the hospital or within 250 yards of the facility? Because if it's where we've moved them and it's convenient for the patient, are we now going to have this issue with significant reduction in reimbursement? So something that I think you need to bring in: site planning, reimbursement, and others. And before we close, Marty, I know we're a minute or two over. I just wanted to comment on the letter that I referenced from CMS related to the correspondence. I'm not meaning to be sarcastic from a hospital perspective. I just want you to recognize that it is so important that you keep things up to date. When you have a record within CMS, within your MAC, that is used for communication, please make sure you address any changes that occur and address them very quickly. That should be one of those little things, even from a compliance perspective, that you include in your what should we be doing, making sure everything is correct with your MAC and with PACOS and other systems.
Last thing is we had a series of questions on virtual services, so chronic care management, remote patient monitoring, and the like. We've decided that is a topic that is big and broad. We're going to wait for the publication of the final fee schedule. So early in 2024, we'll do a deep dive into the billing rules around virtual services as updated by CMS. So mark that on your calendar for 2024. But next up in our HCRR webinar series, our friends in the tax department are taking over because they're going to talk about community benefits and the demonstration of community benefit for nonprofit facilities. That will be on Thursday, not Wednesday, but Thursday, September 28th. Hope you'll be able to join them then. Thanks so much, everyone.
Take care.
Martie, Kathy, thank you so much. And please remember to stay on the line once this webinar disconnects to complete a short survey. Later today, you'll receive an email with Martie and Kathy's contact information and a recording of this webinar, and the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page at PYA's website. That's pyapc.com. While you're there, go ahead and register for other PYA webinars and learn more about the full range of services offered by PYA. Again, remember to stay on the line once this webinar disconnects to complete a short survey and post any questions you may have. On behalf of PYA, thanks so much for joining us and have a great rest of your day.